Hypomania. Now, I just have another 3 slides, or 3, 4 slides, and I'll try to wind up maybe another 5, 10 minutes, and then that. Why is there no hyposchizophrenia? Why only hypomania? Schizophrenia also some mild symptoms, very minimal symptoms. Every schizophrenia is not full-blown first-time symptoms, and then the whole lot of things it doesn't come. Why we don't have it? Why we don't have hypodepression? We call mild depression. And the same thing as hypodementia, we call it as MCA, but why? Like, why these things? See, like, and again, now anyway, not relevant here. People talk about psychotic mania, non-psychotic mania. I never understand that. Is there something like non-psychotic schizophrenia? I did ask also many times a person. Well, why do we, what's the purpose there? What is the utility? What's the validity of it? Right. Now, like somebody was trying to tell that diabetes type 1, type 2, bipolar type 1, diabetes type 1, type 2, there's so much of a difference in the clinical manifestations, insulin dependency, early age of onset, that so much of a difference is there. I don't know about the pathological thing about like an insulin deficiency and all things, but so much of a difference. But this much of a difference is not there in bipolar 1 and 2, except that the episodes are now like, and the hypomania is very, very mild. That's nothing. So you can't justify that they have subdivided into 1 and 2, then I'll also do that. No. These are creating lots of clinical problems if you look into it a little bit. Okay. I don't know whether I can say it, but I want to say it. I have seen few of our own professional colleagues who have nothing but simple depressions, MDD, with a little bit of personality-related, situation-related irritability once in a while. They don't have anything more. They make a self-diagnosis of bipolar 2 and then refuse to take SSRIs because of morbid fear that it's a switch, it's a rapid cycling, and then acceleration, I'll become a flow. They are suffering because they don't take antidepressants. They use valproate, they use oxycodone, they use quetiapine, they use all other things. But so when I say that it's not a simple problem, it's like, because on one side the diagnosis is wrong, on the other side, even if you give a therapeutic trial, people are morbidly scared of SSRIs because of whatever the picture it has been given. This is one thing I see. Very sorry. Refuse SSRIs. What is the canvas of therapeutics in mood disorders? I again and again and again come back to this, which is very, very important when we talk about the chronic conditions like that. At the age of 20, we are dealing with people where the age of onset is at the age of 20, and then we are looking at the long-term treatment. We have to be extra careful, doubly careful, in not only in diagnosis, but talking about long-term treatment, acute treatment for a short period. I have no problem. 3 months or 6 months, you give anything you want. But when you talk about long, lifelong, as somebody asks, whose life, doctor, your life or my life? Something like that. It's like that. We have to be extremely careful. Now, let me see. I'll just quickly run through that. Scenario 1, somebody with MDD, wrong diagnosis of BD2. We all know what the treatment is going to be. SSRIs are prohibited. As I told you that no, don't take it. If you take it minimal dosage for minimum duration, ultimately it doesn't work. You give 5 milligrams or 10 milligrams, it doesn't work. So you say that it's not effective. So that's one, sir. Second, borderline personality disorder, being wrongly diagnosed as bipolar 2. Borderline personality being loaded with all your anticonvulsants and then a whole lot of drugs. Maybe somebody who's improves with SSRIs or what's that? DBT, dialectical behavior therapy. This is what is happening. This is everyday reality, sir. RDD treatment. Here, I just want to. People are there, but sometime back I heard one of the speakers saying that every recurrent depressive disorder is a bipolar disorder unless proven otherwise. My God. We psychiatrists as a clinicians are morbidly worried. See, it's like this, not just a psychiatrist. For a clinician, The most important thing is my clinical acumen. Everybody wants to be very smart in making a correct diagnosis. Great clinicians, clinical acumen we talk about, not therapeutic acumen. So all of us want to make a correct diagnosis. Our problem is we are, I think, is a perception, the kind of thing. I see a patient with depression, I treat him, good. He comes after second time with the depression, good, treat him. Third year, he comes with mania. Oh my God, it's bipolar. Actually, I missed this diagnosis. Maybe I should have diagnosed some time back, which is not possible. So 2-3 cases like this, 3-4 cases like this happen in a sequence like that. I became extremely more conscious about my wrong diagnosis of recurrent depressions or depression, which actually is bipolar. So suppose some mild symptoms of irritable, some mild elation, so make a diagnosis of bipolar disorder, no problem. I'll never make a wrong diagnosis. Is it the kind of mentality we are having that? Or are we overthinking in that? That's what I feel that. Right. Recurrent depressive disorder already with cycle. There's something like a bipolar spectrum disorder where they say that more than three episodes, recurrent depressive episodes, if it is more than 3 episodes, if it is hospitalized, if it is more psychotic depressions like atypical and hypersomnia and all, it's a conversion to bipolar disorder is very high. I think all of you know bipolar spectrum disorder. More than 3 episodes, psychosis, hospitalization, right? Family history, we will see that. It's not like we are morbidly always worried because you give antidepressant, he'll convert into that. I'll quickly run to those slides and they'll come back to this. What is the conversion rate? There's a study which has been like, this is for a 20-year follow-up study, 90,000 patients. Conversion to bipolar from unipolar depression. What is the rate? 8.7%. For a period of 20 years follow-up, unipolar depression to conversion to bipolar disorder is 8.7%. Because of this 8.7%, you want to give 91.3%, keep it as a bipolar and then don't give SSRIs and then don't give correct treatment and expose them to suicidal risk. I don't see any kind of logic. As somebody told that all RDDs are bipolar. Not ridiculous. Right. Family history, we all know. Even here, this is a 2018 study where they said predictors included psychotic depression. There's high chance of conversion to bipolar. Inpatient, high chance of conversion. It's in 8.7%, 8%. Now, let me go to the next slide. This is what the slide shows that over a period of 20 years, this is the percentage of conversion at about 9%. Let's say that. But in the first 5 years, it's a high. Within first 5 years, it's maximum conversion is happening here. I'll show you the next slide. We did talk about inpatients with the high risk. We did talk about unipolar. We talked about psychotic depression. Previous, like where there's high risk. This is a study which is like, and I found in bipolar disorders, just May 2020, latest. You see the conversion over a period of 15 years. Unipolar depression cases over a period of 15 years, again, it's 9%. Unipolar recurrent depressive disorder, inpatients, psychotic depression, over a period of 15 years, their conversion is 9%, 10%. Because there is a 9-10% conversion to bipolar disorder, which makes me feel that I made a wrong diagnosis. Are we making the 90% of the patients with RDD to suffer, not prescribing antidepressants? This is the problem. That is the reason why I am talking so forcefully against the diagnosis of bipolar 2 disorder. It's not that whether the diagnosis is there or not is not the question. The kind of a damage, therapeutic damage it is doing to the patients with borderline personality disorder, patients with MDD, patients with RDD. That's what is happening. It's just 2 studies. Maybe there are some studies which are showing higher, but still, both the studies, 15, 20 years, like what do you want? One is a 15-year-old study, second is a 20-year-old follow-up study. What's the problem? Right. Then some questions are coming, maybe just 5 minutes, I'll complete it and I'll come back to that. Then here, right, scenario 4, MDD, borderline personality, RDD. Now, fourth scenario, it's actually bipolar disorder. I misdiagnosed this as a borderline personality disorder. I misdiagnosed it as a MDD, RDD, or borderline personality. See, what's the problem, sir? Maybe he has come with like a depressive episode, which is definite. The irritability episode is I'm not very sure about that elation, so I misdiagnosed. Okay, I treated with SSRS. Okay, he may get a many when he gets a definite, clear, grandiosity elation. I see a mania, and then I treat him, revise my diagnosis, and treat as MD. One episode of mania is it going to kill entire like cerebral cortex? Two episodes of mania, is it going to produce such a severe neurobiological changes that he will not come out of it? What are we talking about? Good prognosis thing. Why are we so morbidly afraid of this? Yes, I misdiagnosed. But this is horrible. BPD being treated as PD2. This misdiagnosed, second episode, third episode, I'll know that it is PD. I'll come back to lithium. No problem. So this is what, even in the worst scenario, nothing is going to happen. Patient, as I told, that patients recover in about 3 weeks' time. What's the problem like? That's what. Now with this kind of a thing, yeah, I'll just now talk about transdiagnostic. Now we have a clear-cut good prognosis bipolar, and then clear-cut not so good prognosis schizophrenia. Now people are talking about no, there's nothing like that. It's a transdiagnostic. I think you must have heard 2 days back our Keshavan's BSNP study, bipolar and then schizophrenia network for intermediate phenotypes. Even there, when you give the machine learning, even put the symptoms into the machine did not come out with one. It came out with 3 types, biotype 1, 2, 3. Clearly, this is schizophrenia, this is like bipolar, this is related, and this is cannabis drug-induced system. Talking about. So why do we talk about transdiagnostic and it's okay? It's all in the dimensions and all things. No. Anyway, it's not in the purview of this, but still, I just wanted to mention that. Yeah, this we have already covered. Right, sir. I think this is my last slide. This is the latest 2020. Michael Gatlin and Jin Mali, Existential Crisis of BD2. It is our opinion. I put my name also saying that MSR's opinion also added in this. From a conceptual viewpoint, eliminating bipolar 2 disorder would be the most intellectually honest decision DSM-5 or ICD-11 or future diagnostics can take. This is what the conclusion, this is what the last slide I'm talking about. But now somebody may ask, Dr. Reddy, okay, right, you said that it's about quarter century from 1996 till now, even now it's continuing. If you say that it's a myth and it has to be removed, what's going to happen to all those patients who are till now diagnosed as bipolar disorder 2? My answer is, there is some entity called mixed bipolar disorder in DSM-4. DSM-5, it's not there. Lakshmi Atham's book says that 40% of bipolars are mixed type. Where have it gone? There is something like a simple schizophrenia some time back. What happened to all those patients who were diagnosed? Recently, there's something like Asperger's. Which are diagnosed, what happened? The same thing is going to happen to diagnosis of bipolar 2 also. Let us not worry about that. Will be now like some refinement, a valid diagnosis with some utility and reliability is going to come. I think with this, thank you very much.